All right, well, that is my note to get started. Welcome, everyone. Good afternoon. I think it's good afternoon for pretty much everyone, maybe good morning if not. But thank you for joining us as we continue the Chagas Echo for Provider series. This is brought to you by San Diego State University, UT Health San Antonio Echo, the Texas State University, and the South Coastal Texas AHEC. My name's Andrea Roche. I just have a couple housekeeping announcements before I pass things over to Dr. Paula Stigler-Granados to get us started for the day. And let's see, and we're getting a little bit of notification over in the chat that there might be some audio issues. I'll just point Carly, if you wouldn't mind trying to reach out to Jason, make sure they can hear all right. All right, so just a few quick housekeeping pieces before we get started. These sessions are now enabled for live closed captioning. So if you want to view closed captioning for this session, please just navigate to the bottom of your Zoom window, click on that show captions option, and you might need to click on the three dots, the more menu at the bottom right corner of your Zoom screen to find that option. If you're having any trouble accessing that, please just chat Carly with Echo IT, or you can reach out to me as well. To help us with our attendance, please enter your name, your affiliation, and your email into the chat window. It's always great to see where everyone is joining from for these sessions. To access that chat feature, go again to the bottom of your Zoom window and click on the speech bubble icon right around in the middle to bring up your chat window. Also, know that we are recording all of this content and we'll later share it on our Chagas Echo website. So know that any info you put in the chat will not be shared on those recordings, but you can catch the didactic and the conversation later if there are any parts you want to revisit. I'll put the link for that website over in the chat in just a few moments. We encourage everyone to join by video for the discussion portion in the latter half of the session. But that said, we're happy you've joined regardless of how you've shown up today. So thank you again for joining us. There are a lot of us in this room, so just as a reminder, please try to stay muted unless you were speaking, and we do encourage everyone to speak. If you've joined by computer, which I think pretty much everyone has, your mute button is on the bottom left of your Zoom window. If you're on the phone, just press *6 to unmute and wait for the little bit of a lag. You could also use the reactions menu in the bottom right corner of your screen if you want to raise your hand and let it be known that you have a comment to share. But it's also just fine to unmute. It really just depends on how the conversation's going. That said, regardless of how you participate in this session, whether in the chat or unmuting, note that no protected health information is allowed in either space during the entire session. Towards the end of the session, I want you to keep an eye on that chat window. Carly with Echo IT is going to send out a link to an evaluation survey. We ask that you fill it out for a couple of reasons. One, this is your way of getting free CME, so please do fill out that survey. But even if you're not seeking CME, we want you to give us feedback on what you're looking for in these sessions, where we can go with them moving forward, and how they can better address your own learning priorities. So take a few minutes and help us think through the future of this series. Today's session is going to start with a presentation on the epidemiology and infection in dogs with Chagas disease in the US. And then following that, throughout that, we'll discuss a case as well. I should say there are a lot of us here today, so I'd embrace that. And there's a lot of experiences, a lot of perspectives, and I encourage each of you to share those during our discussion. For those of you who might be new to ECHO, just a little bit about the model. It stands for Extension for Community Healthcare Outcomes. ECHO is a model of lifelong learning and guided practice that aims to connect a community-based health workforce with each other and with multidisciplinary subject matter experts to create these virtual communities of practice and learning. The model was developed by a liver disease specialist 20 years ago to support primary care treatment of hepatitis C, especially for uninsured and underserved patients. It rests on a simple realization that you can move knowledge instead of moving people. And if you do that enough, you can improve access to high quality care, you can support the growth of the health workforce, and you can transform community health. So our aim with this series is to build knowledge and skills and understanding among the health workforce about Chagas disease. So we support each other through these regular sessions that include didactics, in cases shared from the community of learners, that's all of you, and then group discussion to share resources and challenges and strategies for Chagas. So a couple of things about this space. This is a space where we are all teachers and we are all learners, so your contribution really does matter. Thank you again for joining us. I'm going to pass the microphone over to Dr. Stigler-Granados to get started with our introductions.
Thank you so much, Andrea. I really appreciate that. I wanted to start off just a really quick introduction of our fabulous team that makes all of these sessions happen. You have met Andrea, but I will let them each introduce themselves real quick, and then I will be happy to introduce our speakers. If you want to start, let's go with Dr. Zhu.
Hello, everyone. I am Zhu Ramamunziarfeo, and I am an associate professor at Texas State University in the Department of Health Administration.
Thank you, Dr. Zhu. And Michael.
Hi, everyone. I'm Michael Vangello. I work for San Diego State University Research Foundation as a research specialist, and I have my MPH from UT Health in Houston in epidemiology.
Thanks, Michael. And Dr. McBride.
I'm Dr. Shannon McBride. I'm a practicing veterinarian, and I am doing an MPH at San Diego State University with an emphasis on epidemiology, and I'm Dr. Granados' research assistant.
Thank you. And Carly.
Hi, this is Carly. I'm working for the Reach Center at the UT Health San Antonio. Very happy to be here, to be the IT person here. If you have any issues with your tech, please chat with me directly. Thank you.
Thank you so much. And I'm Dr. Paula Stigler-Granados. I am at Texas State University and at San Diego State University. It's a long commute, but somebody's got to do it. I have been working on Chagas disease for about 8 or 9 years now, and I have had quite the honor and privilege of working with Sarah Hamer, Dr. Hamer, who I'm about to introduce. And I'm also excited to see the work being done by her and Dr. Ashley Saunders. And so I will read just quickly Sarah's bio. She is really well known in her field, and we are, again, so lucky to have her with us. And she's done phenomenal amounts of work in Chagas disease research. And I'm imagining that's why many of you are here, because we got a pretty quick turnaround on this advertisement and quite a few people registered. So I also wanted to thank each of you for being here today. So Dr. Hamer is a veterinary ecologist specializing in wildlife and zoonotic disease ecology and epidemiology. Her research originates at the intersection of ecology, epidemiology, and conservation, and encompasses diverse taxa like bacteria, ticks, mosquitoes, birds, mice, dogs, humans, and much more. Given the emergence of pathogens shared by humans and animals, this is an important time to utilize multidisciplinary tools to improve human, animal, and ecosystem health. And I know that those are her own words. I've heard her say that before. And she's, like I said, done phenomenal work on Chagas with canines and beyond, and surveillance. And I'm happy to and excited to hear from her. And with that, I will actually have Dr. McBride go ahead and introduce Dr. Saunders, because once we turn it over to this dynamic duo, they're going to be presenting back and forth. So we'll go ahead and read Dr. Saunders' bio now as well.
Thank you, Paula. Dr. Saunders is an associate professor and assistant department head of small animal clinical sciences at the School of Veterinary Medicine and Biomedical Sciences at Texas A&M University. She's a veterinary cardiologist with research interests primarily focused on congenital heart disease, interventional cardiology, advanced imaging, 3D modeling, heart failure management, biomarkers, and innovative teaching.
Thank you, Dr. McBride. Well, we're very excited to have you both here. And again, this is our third part in the One Health series. And this is the one that is focusing on animals and specifically with canines. So I'm going to turn it over to Dr. Hamer and Dr. Saunders, and thank you both so much.
Great. Okay, thank you so much, Paula, and congrats on getting this awesome group here together and your sustained passion for outreach with Chagas disease. And it's really amazing what you're doing for this big, broad community. Thank you for the invitation. I hope you can see, is it the projected view, the title slide? Okay, great. So as Paula mentioned, we're gonna, Dr. Saunders and I are gonna share the time. I am going to start in with some background, very minimal amount of background to the system, and then orient you to some of the more epidemiology level studies that we've been doing with dogs over the years, and then pass it to Dr. Saunders, who's going to take you through some recent canine cases that have come in through the teaching hospital. So if that structure sounds okay, we'll get started. And as was mentioned in the introduction, if you've got a comment, just please unmute yourself at any time and we can make this more of a discussion, please. Okay, so we do not have any conflicts to disclose relevant to today's presentation. And here's the bit of a roadmap that I mentioned with me handling sections 1 and 2, and then I'll pass off for the clinical cases shortly after. So I know this has been an ongoing, this Echo Chagas series, and many of you might have been participating in the previous sessions. So I didn't want to spend too long on kind of a general introduction, but I did want to make sure that we're just all oriented to the system, which is Chagas disease, one of the neglected tropical diseases in that it disproportionately impacts people living in poverty in tropical and subtropical climates. And you can see there on the screen the estimates of the number of infected humans, mostly in the Americas. But what we're going to be talking about today is mostly focused on dog disease. And unfortunately, we don't have really good estimates in terms of the overall prevalence or incidence in different geographic locations. Certainly, we're learning more and more with more kind of focal studies that are being done. But there's a lot of good surveillance effort yet to be done with canine Chagas disease. As you likely know, this is caused by the parasite Trypanosoma cruzi. This is a vector-borne parasite transmitted by triatamines, also known as kissing bugs. And it's just amazing to learn about the host range of this parasite. Just virtually any mammal, it seems, can be infected, with infections documented in at least 150 different species of mammals across the Americas. And in some of those infected animals, we understand, starting to understand more about the disease process, usually cardiac disease or gastrointestinal disease. So this life cycle probably looks pretty similar to the Trypanosoma cruzi life cycle that you've seen in previous sessions, except here in the middle, we have a sleeping dog, which can be fed upon and subsequently defecated on by infected triatamines. And if the infectious fecal material gains entry to the host, then we can have this life cycle of the parasite, which goes from a bloodborne stage to an intracellular replicating stage and back into the blood. And this continues on. And this, as I mentioned, this life cycle, as shown here with the infected bug defecating onto the host, can result in some cases of disease, but also we suspect the main mechanism by which a lot of our dogs here are getting infected is not by contamination of the infectious feces of the bug, but rather through consumption of the insects in the environment. So when dogs eat an infected kissing bug, there can be oral transmission. So a little bit more about the vectors, and I know there was a whole Echo session this summer with in-depth information about these triatamines. Their life cycle is shown there at the bottom, starting with those little eggs on the left, which hatch into the first of 5 immature stages, the nymphal stages of the insect. And then after that, there's molting to the adult, either adult female or adult male. Just a couple of quick remarks on this slide. All of these different life stages will blood feed multiple times. So as you may know, it's just amazing in this system, the amount of vector host contact. And it might be these little nymphs that are feeding on the same raccoon, in the same den, night after night or day after day, or it could be contact with different hosts. The other thing I wanted to mention is that the nymphal stages, the immatures, are not capable of flight. I don't know if you can see my arrow, but this 5th stage nymph is just starting to get these little wing buds here, but they're not capable of flying. So when we're studying, the ecology of this disease out in the field and we're collecting these insects, we can learn a lot just based on the life stage that we find. Finding, multiple immatures in a home might signal a colonization event, right? Because they're only able to crawl. So they might actually be infesting that area, versus if we find one or a couple adults, they could have dispersed in, they could have flown in, attracted to a light or another source of carbon dioxide in the environment. Okay, so I mentioned this vector fecal mode of transmission, which is shown in panel 1. And I also alluded to oral transmission, which is shown in panel 2. And I really would like to emphasize that although it's very hard to demonstrate scientifically, we have reasons to believe that there's a lot of oral transmission, and that probably explains a lot of the animal infections, dog and wildlife, that we're finding across the landscape. There are other modes of transmission that you may be familiar with, shown by these other panels, but we don't have much information about how relevant they are for veterinary medicine. For example, blood transfusions. We know, of course, there's donor dogs and donor cats, and we tried to dig into this a little while ago, but a lot of variation in the degree to which donor animals are screened for infectious agents, including or excluding Trypanosoma cruzi. So just some maps. These come from a really nice review article that's, goodness, over 10 years old now, that's cited on the bottom. But the point here is that we can recognize in the southern United States, this Chagas disease system as certainly being enzootic, in the sense that we've got a wide distribution of infected vectors, a wide distribution of infected wildlife reservoirs that are likely serving to maintain this parasite, this transmission cycle. And under some circumstances, there can be bridge transmission to humans or to dogs that might account for locally acquired human Chagas disease in the southern United States. And you likely were exposed to these data from previous presentations, but there's increasing recognition for autochthonous cases of Chagas disease in the United States, with a nice review paper kind of tabulating those numbers that have been reported in recent years. But I'm sure we might agree that this is probably the tip of the iceberg of infected people. So these animal infections, we will present to you some case studies today about dogs, and it's amazing to, continuously be reminded about all the diversity of dogs that appear to be at risk for infection by Trypanosoma cruzi. This includes hunting dogs, the government working dogs. I'll share with you just a bit of data from our research with them over the past years, household pets, as well as shelter dogs. And wildlife, we have some data that we've been working with raccoons, possums, wood rats, but the list goes on. And again, increasing appreciation for infections in captive animals. So whether these are animals in zoological collections or exotic animal ranches, the list continues to be expanded with infections of animals in the southern United States by virtue, most likely, of locally occurring infected insect vectors. So I wanted to just make a couple notes here, and again, echoing what you may have heard from other professionals in this session before me, but the diagnosis of Trypanosoma cruzi in dogs, much like in humans, is complex. And we often, hope that we can continue to improve the tools that we have available to assist in making a diagnosis. And part of the complexity is if we look at the cycle of infection, the infection dynamics, which is what's shown here in this really nice review paper that I recently was made aware of that was published late last year in Parasites and Vectors from a research team in Bahia, Brazil. But we can see here that the period of time of parasitemia, when the parasite is in a higher density in the blood, shown by this orange line, might occur quickly after infection, and then tapers off, and then there's a lower level of parasite in the blood. So if we had an acute infection or a time when we knew there might be a parasitemia, then it might make sense to use diagnostic techniques that would focus on finding that parasite in the blood, whether that's microscopy of a blood smear or using molecular techniques like PCR of the blood. But after some period of time, the parasite is less likely to be detected in high number in the blood. And that's why the antibody detection tests can be so powerful. In this system, it's accepted commonly that an infected host is probably infected for life and will maintain an immune response to the parasite in the absence of any anti-parasitic treatment. And so in veterinary medicine, most dog diagnoses are made based on an antibody test. And one of the main go-to laboratories for veterinary diagnosis of Trypanosoma cruzi infections is the Texas Veterinary Medical Diagnostic Lab, which is TVMDL, which is actually right here on our campus. It's part of the Texas A&M system, but is separate than our vet school and separate than the university. But there they offer a validated test called the IFA. It's an immunofluorescent antibody test, and this can detect antibodies to Trypanosoma cruzi in a serum sample from a dog, and they can generate information on the endpoint titer as well. So moving forward, I wanted to let you know just briefly the vectors, these kissing bugs. We do have a program here based at Texas A&M University, and we worked closely with Paula and the Texas Chagas Working Group and a lot of other stakeholders in the state. And we've received a lot of insects through this program. In fact, insects from 28 states have come in through this program. And we work now with researchers in different states that have kind of statewide community science programs, for example, in Florida and Illinois and Missouri, and route bugs to them. We also work very closely with state health departments if there is a portal, especially in the case of bugs that are disclosed to have fed on humans or been found in a bedroom. We always engage local health departments there. And in many cases, they can route the bugs for eventual testing at the CDC as opposed to our research lab. But we're very happy to be kind of a source of information and help you route your insect observations to the right parties. And please know that any information coming in is very valuable. Each of these insects provides a wealth of information and great learning opportunities for undergrads and veterinary students to learn about these vectors. And overall, just with a subset of the insects that have come in through our program, many of which come in through veterinarians, many of which are disclosed to have been found in and around dog kennels, we found about 60% infection prevalence in the adult life stage of various species of kissing bugs. And just notably and briefly, about 3/4 of the insects from this community science program are found outdoors. So it's more rare for them to be found indoors. And when we dissect the guts of these insects and use molecular techniques to try to figure out what they've previously fed, again, with a small sample size of bugs just coming in through this community science program, I'd like to emphasize the importance of dogs as a blood meal host for these insects. About half of these bugs have evidence of having fed on a dog, but there's a lot of other hosts as well, shown by these different colors of the pie. And those are insects that, again, it makes sense because often, as I mentioned, they're disclosed to have been found at a dog kennel. But I want to now show you this more complex figure, which comes from the work of DVM PhD student Rachel Busselman, who's shown there. And this was recently published in a review paper about veterinary Chagas disease in the southern United States. And what Rachel did is she compiled all these blood meal analysis studies for kissing bugs from the southern United States. So all these different species of United States kissing bugs are shown up here. And then the hosts upon which they were determined to have fed are shown by the black bars at the bottom. And all those diagonal lines represent individual blood feeding events. And just from a broad takeaway, we can see dogs certainly are represented there, but not half the blood meals. It looks to be about 1/5 of these observations seem to be with dogs. We also have rodents and humans standing out as heavily used hosts by these vectors. So to reiterate some of the messages that probably come up in any talk about Chagas disease, we recognize there's limited and imperfect diagnostic tests. That's true for vet med. Limited options for treatment. That's true for veterinary medicine. No vaccines. These widespread, heavily infected vectors and wildlife reservoirs. Vector control is quite a challenge. And of course, awareness is a problem. But thank you to Paula and her efforts. Hopefully a problem that's being worked on. So now, just with a few more minutes, I'm just going to share with you some photos and findings from some of our work with different dog groups, more at the population level, and then again pass it off for the clinical updates in a moment. We started into looking at dogs at animal shelters. This is several years ago now. And what we found is that across all of these different ecoregions in Texas, from far west Texas to the South Texas and the Rio Grande Valley, up north to urban areas like Fort Worth and Dallas, we were able to find dogs with antibody responses or PCR positive results for Trypanosoma cruzi infection. And the prevalence of dog infection in these shelter environments was about 18% overall, and statistically indistinguishable from the prevalence of heartworm infection in these same dogs. And moving forward, there were some focal regions that we've been working in for several years now, including South Texas, where there's communities known locally as colonias, which are impoverished, predominantly Hispanic communities right along the border. And because of the quality of housing in many of these communities and the abundance of stray animals as well as owned dogs, we thought that these areas might be at high risk for Trypanosoma cruzi infections in both humans and dogs. And so we were able to conduct a One Health investigation, sampling people, sampling their pets, and doing a lot of culturally competent outreach in these areas. And just from the dog data, what we found briefly was about 1/3 of these animals met the positivity criteria for the study, which in this case, it was reactivity on at least 2 independent antibody tests or being PCR positive. And it was spread out across all of the different colonias in which we sampled. So 1/3 of the animals. And then we've really been keying in on dog kennels, these multi-dog kennels where there's a lot of dogs living in close confinement. And there's a lot of these kennels across Texas as potential hotspots for transmission, because some of this early time-lapse photography done by Rachel Curtis Robles and other colleagues, you can see these time-lapse pictures taken at 15-second intervals of the sleeping dog. And you can see a kissing bug creeping in, and then it's in contact with the dog's foot pad, and then it moves away. And so certainly this might be happening night after night. And these dogs have this really heavy force of infection that might occasionally result in successful transmission. So a little tidbit from a recent study that we published is it was an incident study. So it required starting with a population of dogs that were negative and following them forward to try to measure new infections that happened in these kennel environments. And what we found by tracking about 32 uninfected dogs and testing them at 6-month intervals is that nearly 1/3 of them converted from negative to positive over a 1-year time frame. And often we saw them first go from PCR negative to PCR positive, and then they became antibody positive. And so this was just an indication that in the right environments, these infections are happening annually. So I'd like to just pull up the first poll question, if that's possible. I've prepared one poll question, and Dr. Saunders will have one as well. So hopefully we'll see that on your screen. It should be the other one. Do you have a second one in there? You can close this one down, please. This is not the right question.
We'll try pulling up poll 2, I think, Carly.
We were just giving them a preview so they could get there.
Yeah, no cheating,
Google it.
no Googling.
We'll hope we can pull it up, but if
Is
not,
it showing the poll 2?
I can't see it. I closed out poll 1.
Try it one more time. As a co-host, Sarah, you might have a different view than our
Okay.
participants. Carly, try launching poll 2 one more time.
Yeah, there it is.
There we go.
Thank you. So the question is simply, like seeing this data on these new infections happening, when do you think new dog infections are most likely to happen and why? That might be hard to answer in a poll now that it's not like an ABCD answer. But I was wondering if anybody might just unmute yourself and offer any thoughts on this, maybe seasonality. We might be able to see some of the written responses in a moment as well. And while we're waiting, coming into this, like we had some pretty good information on the vector seasonality and phenology, and at least with all the biases of that community science program that I mentioned, when were members of the public, when were they most frequently encountering insects? And there certainly was seasonality there, but kind of coming into this study, we didn't know what to expect with capturing new dog infections and seeing when they would convert. We can probably call it there, if that sounds okay. Looks like we've got 16 responses.
Yeah, I think go on in the poll and we may be able to share the results. Carly, I'm not sure what the view looks like with a free text. I think it might not show the granularity of responses that might only be available in a post-session report. So maybe some of you who answered, if you wouldn't mind unmuting or throw your answers over in the chat.
I'll unmute. I said summer. I'm just guessing though.
Yeah, summer certainly when we encounter them.
I'll send the detailed link in the chat so you can see all the answers.
Oh, great, thank you. Yeah, we were surprised. We wanted to capture all these negative dogs for a few reasons. We did really intensive sampling in March and April, and gave the dogs a status of either positive or negative then. And then even with data not shown, even a few months after that, we had a lot of new infections. So within sort of the April to June time period seemed to be really risky for the animals. And then later summer, there were still some new infections, but much less than early summer. So it was that late spring, early summer timeframe when we saw most of the dogs seroconverting, PCR converting and or seroconverting. Okay.
I would think that they might have evolved to be feeding when puppies are generally born, because then they'd have naive hosts.
Mm-hmm. Yeah, so thinking about this like seasonality of when puppies, these susceptible, naive hosts that might not have any anti-vector defense yet. Yeah, so there could be something to that as well. Or maybe not just dogs, but new mammalian hosts in general, wildlife when they're being born as well. Are there any other thoughts or comments before I move forward? Thanks for launching that poll. So vector control, I'm not going to talk about that today, but I just want to plant the seed as I play this video that, man, vector control would be hard. This is a kennel that we're looking at where they have had problems with canine Chagas disease, canine deaths due to Chagas disease, and incident, new infections that we were able to measure. And so for a few reasons, we were doing systematic vector collections using a combination of manual searches as well as lights and traps. The traps never work out that well. But here we are just outside the kennel perimeter, and you can see this nymph that's about to be captured. And this was just by moving some of the woody debris and being able to find this insect. So the whole point of that video is just so you can see that, like, we can put all of the insecticides, barriers around the kennel to try to protect the focal animals that are inside, but it really seems to be this pervasive threat of these endemic insects. And you can see the little critter here that might have been a blood source, we're not sure. Okay, so I mentioned how this parasite is impacting all sorts of dogs, from dogs in the colonias of South Texas, and now these very high value working dogs. And the data I'm showing here is from our work with the Department of Homeland Security. For a few years, we were able to have funding from DHS, and they were very interested in the degree to which this parasite was impacting dog work performance, dog health. And so through a nationwide survey, we found infected dogs across the United States, including in regions where we would expect to find them in the South where the vectors occur, but also in some northern states. And this might be a function of these dogs having trained in areas where vectors occur and then moved to areas of the north with that infection. Important to note that in most cases, these dogs that had this infection were reported by their handlers to be active and performing as expected. We were able to also continue our studies and do some clinical workups on infected and a matched cohort of uninfected dogs, monitoring their cardiac health using 24-hour ambulatory Holter monitors and other devices, and trying to follow them forward to look for changes in health over time. And just in a nutshell, as expected, we found more cardiac abnormalities in Chagas positive dogs as compared to Chagas negative dogs, and that's shown by the red bars versus the blue bars. And we also found that this cardiac troponin I, which is a biomarker of cardiac injury that Ashley Saunders will tell you a little bit more about, was elevated more commonly in positive dogs than negative dogs. In many cases, as I mentioned, these dogs were able to continue their working duties despite having this infection. But in other cases that wasn't true. And this comes from a case series that was published on the death of 5 government working dogs within a period of 6 months. And these were dogs that were either enrolled in our studies or we were able to obtain samples from them either before death and or after death to confirm the diagnosis. And although I've mentioned, and this is the last slide that I've got, although I've mentioned, with these case studies of the government working dogs and the border dogs, a lot of emphasis on Texas. This certainly isn't just a problem in Texas in terms of canine Chagas disease. This table and figure comes from this recent review paper that I mentioned earlier. And in terms of their systematic review, the studies that met their inclusion criteria for purposes of their review are tabulated here. We can see the prevalence of infection in dogs from Texas, a couple of studies in Louisiana, Oklahoma, and so forth. So it seems the more investigators are out there looking, the more we're able to get information on these dogs. I would like to pass it on to Dr. Saunders now. And I'll stop my share. Ashley, I think you were going to do that from your end, right?
That'd be great.
Great.
Okay. Does that look okay for everybody? All right.
Looks great.
Awesome. Thank you for letting me speak with Sarah and tell you a little bit about the clinical work that we do. It's definitely a great collaboration that we have. I think we're both really, really super lucky to have each other to work with, especially down here where we're seeing so many of these cases. So I brought up this slide again that Sarah showed a little bit earlier, just because I watched a lot of the prior echo sessions, and it was so fun to see all of the different aspects of the disease and in the human field, and then just how similar it is for us with our dogs, and how so many of the struggles that were described are very similar things that we deal with, of course. And so we deal with imperfect tests. It's hard to make a diagnosis sometimes, and what tests to use and the options that we have available for us. Treatment for us is an incredible challenge that we continue to dive into and try to tackle. And then just awareness, again, is just so limited that we deal with that as sort of a constant, the constant thing that we deal with, basically. So a lot of the same things that have been talked about in previous sessions, dealing with humans and dealing with that population is very similar to what we deal with our dogs. This is a paper that was just accepted that we put out just to raise awareness, essentially. So this one is, it describes 12 dogs that were identified with Chagas disease outside of Texas, but had been living in Texas. Many of them had been transported through some of it was just families who had moved, but some of them were transported based on just different things. Sometimes it's related to like weather, like you have a hurricane and dogs get redistributed. So many of these dogs have been redistributed. But again, we're diagnosed in states up in the northern part of the US. And then also we did a survey of veterinary cardiologists, and of the ones that, and just trying to figure out about their understanding of Chagas, their awareness, and how they approach cases, or do they consider it as a diagnosis. And in that group of responders, there were about 49% of the surveyed cardiologists that indicated they had limited knowledge of Chagas disease. And that was from cardiologists in the United States. And so we just were trying to put it out there. We need to continue trying to raise awareness, not only for the human field, but also in our veterinary field. So this is the first sort of case, but it's a consult that is very, very frequent for Sarah and I and the people that we work with. So it's a very, very, very common consult, I would say almost on at least a couple times a month, if not weekly basis. And so a veterinarian reached out to me and said, you know, that they're owners, they're of a dog, that they live in Texas, that they had stepped on a blood-filled kissing beetle, is what they told me, that was around their 9-month-old boxer puppy, and they wanted to get ahead of the Chagas disease. And so the veterinarian had reached out to a diagnostic lab about trying to test the dog, or what, you know, what approach should they take with this case. And the veterinarian was great to talk to. When I talked to them, they said, you know, I knew about this a little bit in school, but it's just been so long. I was trying to update myself on, you know, how to instruct the client, the owners, about what to do about their dog. And so the recommendation was to test the dog in 21 days. And I will tell you that the clients of these dogs do not want to sit and wait on anything. And so waiting for you know, to test a dog and figure out if it had been infected is like, people do not have patience. And so the question that was posed to us was immediately about what's the current recommended treatment protocol. And so I would say that is a very, very, very common scenario for us, that we're asked about immediately. What's the treatment protocol for these dogs? So I don't know, I had this was one of our poll questions. So like thoughts, recommendations, what would you do next? I know what I typically say, but I'm curious if other people have thoughts. And so I've posed a few that you can answer in the poll. And if you want to, we can also close it out in a minute. And I'm happy to hear anybody else's thoughts that might not even be included in this poll.
Thanks, Carly, for launching the poll. You should see it pop up on your window, unless you're a co-host. So Ashley, Sarah, you may not see it or be able to answer with it.
I can see it. Yes, it's
You
great.
can see it. I don't think
Yeah.
you can respond. So you can, you can only see the responses coming in. We'll give it a little bit. Looks like we've got 30. Oh, we're going fast. 42% participation. I think we can get above 50. That's my goal. We sailed past 50.
Yeah, it's great.
I think we could probably stop and poll and share the results, Carly and
Yeah.
Ashley. Yeah, take it away.
Yeah. So yes, so like 69% of people said they would confirm the insect is a reduvid bug. Below that was test with PCR, and below that was perform a blood smear, and then a few people said start treatment. So this is sort of the approach that I take right now. Let me see if I can. I just need to close the poll. There we go. Okay, so the way that I approach it a little bit is just education, because I know that these veterinarians are going to encounter these scenarios maybe more often than I will, especially if they live in certain areas where there are a lot of reduvid bugs, or in places where people know about it. And so the first thing that I usually talk to them about is confirming that the bug was actually a reduvid bug, and I point them to Sarah's lab website, where they can look at pictures and then also decide about submitting one for identification. And sometimes they'll tell you, you know, that bug's long gone. Sometimes we get lucky and they still have it around. It's in the freezer or something like that. And so I ask them to figure out if there's, you know, are there other bugs in the environment? Have they seen them? Like, do they know what they look like, and they know that they're around, or they've never seen it before and they just had heard about this kissing bug and that's what they think they have. So it's just a little bit of education, trying to figure that out. And then I'm also trying to talk to them about, there's a very strong push in some aspects for some people to go straight into, like, you know, like that their dog's infected and it's going to die. And so again, just trying to educate them. So one is that I think it's really important because people don't understand that the life cycle of the bug and how the transmission occurs. So I just reiterate some of those things that, and Sarah pointed this out too, but when you have a insect that is feeding on an animal, that doesn't mean that it's been transmitted. And that's not the way transmission occurs. So one is trying to talk that out with them. And then also that when they think sometimes that they're going to get, they don't want to get like, well, the getting ahead of Chagas. If they do have kissing bugs in the environment, then there are probably also other kissing bugs in the environment, not just that one. There might be some of the nymphs, there may be other bugs. And so the exposure to that dog could be repeated or may have already occurred or could now have infected some of their other animals as well. So it's just putting that whole scenario on their radar. So I think a lot of that education is really, really important because otherwise it just some of it gets perpetuated that that people just don't understand. So we work on that and talk to them about vector control and the whole gamut of that. And then start going into diagnostics and treatment. But I wanted to talk about that because I think it's really important for us to do that education piece and not just be jumping to treatment when we don't really have a full picture of what's going on with these dogs. Any other comments or anybody have any comments on that one?
This is Paula. I was going to say too, one of the things we've been talking about is also communicating human risk as we know that it's lower, obviously it's higher for dogs because they do eat them and sleep on the floor. But then, you know, how do veterinarians communicate that human risk possibility and maybe even communicate how to talk to their doctor about getting human testing? Because that seems to be also where some things get stopped. But we tend to recommend if your dog has Chagas disease or is diagnosed positive to consider that you may have been exposed as well and to consider testing. So I don't know if that communication is happening, but hopefully moving forward with that One Health perspective, that'll be something that we continue to do as well.
Yes, that's an excellent point, and we do get asked that a lot. And I think it's a tricky one because some of the questions will be like, should we euthanize our animals so that it doesn't infect us? And then also, can I be infected? And so we are always careful not to give medical advice to them, but we do say if you've been around, if you know the insects are around and you've even found them in your house, or that you should reach out and talk to your medical professional. And then sometimes I always tell people, sometimes you have to even like tell them what you're looking for and here's what it's called, and like do a little bit of the prompting because they may not be familiar with it. All good points. Okay, so I wanted my next case is mostly a description, so you can see that a lot of the cardiac disease is very similar to what is seen in humans. So this was a boxer puppy. It was a 10-week-old male puppy that came in on emergency evaluation to its veterinarian and had ascites and tachycardia. And they did a preliminary ultrasound of the heart and said that it had right-sided heart enlargement and said that it was probably a congenital defect and sent it to A&M for us to look at on emergency. And my resident called me and said, we've just seen this puppy. It's got to have tricuspid valve dysplasia because its right heart is so big and dilated. And he was new, had just moved to Texas from another state. And I said, oh, there's this other thing that you're going to have to now put on your radar, because this dog's tricuspid valve was actually very normal on the echo. And it was that the right side of the heart was severely dilated, and the dog was in right heart failure. And so our top differential would be Chagas disease or some other kind of myocarditis. So this dog, when it presented to A&M, had a wide QRS tachycardia that was unresponsive to lidocaine that was administered in the emergency room. And again, we confirmed on the echocardiogram that the right heart was severely dilated and that the tricuspid valve was actually very normal. And then shortly after presentation, the dog arrested and died suddenly, and they allowed a necropsy. So this is this dog that started this this whole case report. This was the first dog that came in, so we call it the index puppy. So this puppy came in and had its necropsy, and I had to include an echo for the echo session because here's your ultrasound here. So this dog has, this is a heart upside down, the left atrium and the left ventricle, and then the right atrium and the right ventricle are labeled there for you, and they're just not moving. They're hugely dilated and have reduced motion, especially the right ventricular free wall, so just not moving. This is very common with some of these dogs that are really severely infected. And then on the pathology, it was just horrible myocarditis. There was almost no myocardial cells left. So it's just this really, really wicked myocarditis. So this dog, when we talked to these people, they said, oh yes, there's a whole litter of puppies. So we contacted the breeder, and there was still the mother and then 3 litter mates, and they wanted to bring them in for us to have them evaluated. They had seen lots of the kissing bugs when we showed them pictures in the environment, and the puppies were housed outdoors in a cage. And so we had these dogs all come in for a cardiac evaluation, and all 4 of the dogs, so the mother and the 3 litter mates, had normal physical exams. We tested them and they were IFA negative for T. cruzi. And then we do, I saw this in a previous session where they talked about biomarkers, and we do a lot of biomarker work. And so we were looking at troponin, trying to use it as a marker of myocardial damage. And these dogs had fairly low troponins, except for one that had a 0.8 nanogram per mil, which is like not crazy high by any means, but it is a little bit higher than I would expect, and it's definitely out of the range of normal. On the EKG, we did a 5-minute EKG, no abnormalities. We echoed all of the dogs, and only one dog had subjective mild enlargement of its heart, and it was the one that had the highest troponin. And 2 weeks later, that puppy died suddenly at home, and they allowed us to do necropsy on it, and it also had a really severe pancarditis, just like the initial puppy. So this work that was done really early on was some of what's prompted us to really look at troponin more closely as a marker that could give us an idea that there's more going on in some of these dogs, then that is the marker that's telling us that it's there before they test positive. So we've done a lot of work with troponin since then. So I was going to show you just very quickly again, just about when we look at the cardiac disease, that some of the things we see very similar. So when we looked at retrospective analysis of these dogs that we see in Texas, we've got dogs we can show that have ventricular arrhythmias, combinations of arrhythmias, and then elevated troponin in many of the dogs. And then we can also show that a Holter probably tells us more than an EKG, an in-house EKG. And so that was something that we found in one of these studies where we looked at dogs. And then our AKC study that we've just wrapped up, this just shows you in the green. This is looking at standard lead EKG abnormalities versus Holter abnormalities. And the Holter abnormalities, it just detects so much more. And so it gives us a better idea of what's going on, which allows us to track things better, and then also try to determine treatment studies and look at different things better when we use the Holters. So that's included for you. So we really just are using a lot of the work that we're doing to just keep on keeping on. So we're trying to figure out about ideal diagnostic tests for practitioners out in the, that are seeing these cases all the time, and then just trying to figure out other ways that we can try to help with prevention and treatment for these dogs. How do we prevent sudden death? Because that's a huge problem for the owners of these dogs. Heart failure is a problem too, but sudden death is really a major problem, and just raising awareness. And then how can we use a lot of the information that we're learning to help with the entire global One Health look at this disease? And I think that was sort of the the end of it. This is just a lot of the people that Sarah and I work with, and we can't do what we do without them. So we wanted to list them and show them here. And so with that, I think I'll wrap up because I know it's getting towards the end of the hour.
Thank you so much, Dr. Saunders, and Dr. Hamer. This was fantastic. I'm going to open it up and see if there are any questions that we didn't answer in the chat, or if you can put them in the chat or just unmute yourself and ask questions. One question I will start off with is thinking about now that I'm over here in Southern California, where we do have triatamines that are infected. And I know Dr. McBride has already tested a dog that was suspect of potential Chagas disease, which I believe was negative. But I was still excited that she had even thought to, maybe possibly test this pup. I'm just curious if you have advice, like you started to say, sort of the questions are for people that don't see that as frequently, I would just imagine, as like we do in Texas. For some of our veterinarians and public health people that are here in California, I'm wondering if you have advice on them of like where they would send a test to, or if there's a place that you would recommend them calling. That was the question Dr. McBride had brought up, is like, where do I send the test to? And I don't know if Shannon, you want to add to that question, but just curious if you had advice.
Yeah, for me, I sent it to one of the diagnostic labs who then forwards it on to the Texas lab, which tends to be a little bit more expensive in that way. But this was a 2-year-old bull terrier that was born with some sort of heart condition and had not been tested. It wasn't a true congenital defect, and so they weren't quite sure what was going on. Also had some GI symptoms, so that's why we sent off the test, and it ended up being negative in this particular case. But for veterinarians, you can either send directly to the Texas lab or through your diagnostic lab is usually the easiest way.
Thanks. Any other questions? We have something in the chat. 6 in Yucatan in Mexico, we found that 6 out of 10 pregnant seropositive dogs can transmit the disease to 20% of the litter. That's about to be published. That's fascinating. Not surprised, but it's fascinating. Have we done a lot of congenital looks? I mean, it sounds like Dr. Saunders, you were mentioning congenital transmission. In the case with that one pup that did die, was it congenital? You said the mom was negative on that one, correct?
Yeah, so I think those were probably infected by the insects that were all out around these dogs. They were born during the summer month, like in the summer. So I think that's how they got infected. I don't think it was congenital. I know Sarah has a little bit more about that, but I don't know if she wants to speak to it or not.
Yeah, I'm excited for the study coming out of Yucatan. So thank you for sharing that. It's been hard. Like, we've long been interested in, because there's dog breeders that will come to us and maybe they know that the dog they'd like to breed, the female is positive. So, they're ethically, should they breed that dog? What are the chances that the pups would be born with the parasite? And there's just not a lot of data to be able to answer that. So completely independent of our research, we were able to track a couple of litters that, based on owners' decisions, they bred seropositive dogs, and we were able to track the mother's infection status and then that of the pups. And in the case when a couple pups died, we were able to get them into necropsies. And in the one, and this is not yet published, but in one case, initially, all the pups had sky-high IFAs, which might be expected for maternal transfer, maternal immunity. And then we saw those titers drop. And then 2, 3 of the pups ended up being PCR positive, 1 died. But in that case, it was not possible to tease apart congenital infection versus acquired from bugs in the community, because they were living in an endemic kennel environment and there were kissing bugs around. So did those puppies independently encounter insects? So it's a tough research question.
Thank you. Thank you. That sounds like there's some direction there for some future research, but that's fantastic information. I just wanted to share really quickly as we wrap up, Dr. Cropper lends us some great food for thought here. When dogs are positive, it would be helpful to have a website for veterinarians to use for educating the owners about Chagas and concerns about human health and how to communicate with their physicians. And I really appreciate you sharing that. And I would agree with you that it's a struggle that we've had with trying to get people to realize that, you know, risk is low, but it's still possible if they're living in an environment and sharing an environment with triatamines, that chance of infection, especially if they're in a highly endemic, or I guess it's not endemic, but you know what I mean, area such as Texas, it's not a bad idea to be tested. And thank you, Dr. McBride, for sharing that resource with us as well. And I know we are actually at 2 o'clock, a little bit over, and I just wanted to say thank you to both of our speakers for this incredible information. I feel like this was such an amazing presentation. I learned a lot. And you all, if you have further follow-up questions, feel free to reach out to us. And there's an evaluation in the chat. We'd really appreciate you filling that out, especially if you need CME credit. And we are, just for the veterinarians in the room, we are actually working towards getting CME credits for veterinarians in the very near future. And so I really hope that we can get that established so that we have more opportunities for you all to get the continuing education credits along with the medical providers as well. And so with that, thank you all again for your time this afternoon. And we are excited. We will be having our next ECHO session, fingers crossed, in February, where we will be talking about human congenital infection with Dr. Morven Edwards. We're confirming that possibly for Valentine's Day. So I'm thinking there might be a kissing bug Valentine's Day theme happening. And we will be happy to send that out to you all. You've registered, so we have you on our list now. We'll send you information for future sessions, and we really, again, appreciate your time. Thank you all so much. Some of us might stick around a little bit if you have some more questions, but otherwise, thank you again.